So now we move on to the next talk, which is very interesting, mastering the Miloop nuclear fragmentation devices. Dr. Sartaj GREWAL.
Hi, good evening, everyone. Really appreciate you all taking out time to be here for this. So just continuing with Professor Jagatram sir's talk, I will be discussing the Miloop, which is a device that has now been around for some time. It's marketed by Zeiss in India. Uh, not all of us will have skillful hands like Professor Jagatram, where you can do direct chop or even stop and chop. Some of us, for whatever reason, might not be very comfortable with SICS. So that is where tools such as the MyLoop really come in. I am a consultant for Carl Zeiss. Dense, brunescent, maybe black cataracts like these, we come across them in our clinical practice, especially in India, as we discussed earlier. These can pose a challenge for even the most experienced phacosurgeons, can give us a sleepless night the night before the surgery. And these can be challenging, as Sir discussed. The entire nuclear disassembly process is a challenge. Not is it just that, chopping them at first, but every piece, getting it out when they're leathery is just a constant struggle. So what if we could just divide them with almost no force whatsoever? And that is where the Miloop comes in. So this is a nuclear fragmentation device that is made with a nitinol filament. When we were discussing technology, this is one that is excellent for hard cataracts, certain other complicated situations. You can combine it with other technologies that are available, such as flax, and with absolutely no energy at all, it can divide into 2 or 4 pieces any density of cataract that you have. So it's a micro-thin filament that's retractable, super elastic. It is self-expanding. The filament itself has a diameter of 300 microns. Fully expanded, it has a horizontal diameter of 10.5 millimeters and an anterior-posterior length of 5.5 millimeters. So this is enough to engulf even the largest of the nuclei that we'll come across. And when it's fully retracted, it has the loop itself has a diameter of only 1.5 millimeters, so it can easily go through a 2.2 millimeter incision. So I'll just briefly discuss how do you use this device. It seems very traumatic in the videos, but it really is not. It's a very safe device and very easy to use. The first step is inserting the Miloop, and this can seem a little trickier than it is. What you have to do is you have to center the loop on the incision, engage the incision with the loop itself rather than the shaft of the device, push down, and then sort of take it towards the side and then enter with the shaft. Once you're inside the eye, you just have to make sure that the point from where the loop opens, this should be centered on the capsular axis itself. You want to gently rotate the device so that as the filament is opening, it gently scrapes against the nucleus, maybe even just going underneath a little bit of the cortical matter. This increases your chances of making sure this goes underneath the capsule rather than over it and hitting the zonules. Once it's opened up, you can see the filaments. They should be relatively straight. This tells you that you have opened them up adequately, because if you don't open it adequately, you'll end up putting more force on the nucleus itself and the zonules. In most cataracts, even if they're dense, you're able to see a shiny reflex at the back. It's a good idea to just sweep the filament across the posterior surface. This helps in dissection and also just polishes the capsule a little bit. Make sure that before you retract the filament, make sure that you're right about in the center. This will increase your chances of getting 2 equal pieces. A second instrument is very helpful in stabilizing the nucleus, because when you retract the filament, it does tend to pull up the nucleus a little bit, which can damage the endothelium. Once you have made 2 equal halves, you can easily rotate it and then go ahead and divide it into 4 pieces. Once it is divided, it is important to just use the second instrument. Make sure that you get the filament out. Some of the very leathery cataracts, it can be a little sticky. And when you're removing the device, the edge of the loop can be like a hook, so make sure you rotate it adequately so that it doesn't engage the capsule or the iris as you're pulling it out. So I'll just discuss a few different situations where you can use the Miloop, and it really helps. So this was an 86-year-old female with a dense cataract, poorly dilating pupil, and some phacodonesis. So we went ahead, we did the capsulorhexis, and I used the Miloop after that. And you can make out that the nucleus was reasonably mobile, but the fact that, as Dr. GREWAL mentioned earlier, forces. The force that the Miloop is applying is purely centripetal when it is cutting the nucleus. It is not applying any force tangentially or anywhere else. So you can very easily use this in situations where the zonules are not very strong. So I just divided into two. I didn't want to rotate it because I was a little afraid about the zonules, but when I went in to try to chop, it was actually quite mobile and rotating freely. So I actually decided to come out and go back in again with the Miloop and use it to actually then divide into 4 pieces. That's the other good thing with the Miloop, that it's not that you can only use it at one particular stage. You can use it any time in the surgery. Even if you have a failed chop, let's say, and you want to switch over to the Miloop as a rescue device, you can do that. So then I went ahead with 4 easy pieces. It's quite easy to just go ahead and emulsify these pieces. And as someone was mentioning that, when you're starting off, if direct chop is very tough, this is a very good way of getting smaller pieces, learning how to handle these really dense quadrants, and then you can progress to chopping a whole nucleus intact. I placed a CTR, then went ahead, removed the remaining pieces that were there. And it was a fairly successful outcome with the bag in the lens, with the lens in the bag. Just be careful with the cortical material removal. With the CTR, it can be a little tricky at times. This next case was where I had missed the phacodenesis preoperatively, or could have been a little iatrogenic also at the time of chopping. So we can see over here superiorly that this nucleus is actually quite mobile. So I went ahead, I placed a CTR, and I used the Miloop after placing the CTR because that gave me some support. And it was quite easy to actually get the Miloop in, get it around the nucleus, divide this into smaller pieces, which then could easily be removed, and eventually, again, IOL single piece in the bag. So it's a really versatile device, not just for hard cataracts, but a few other different situations. Another situation where I actually like to use it is small pupils, especially patients with IFIS, because when you try to do a hydrodissection in these patients, it's very likely that the iris will just come out at that time itself. Even hooks and rings have limited success in patients with IFIS because that pupil is just always ready to come out of the wound. So I find that I can just go ahead with this device, finish a capsulorhexis. If as long as you open it in the right direction, making sure you're going along the cortical matter, you will be inside the bag. You can go around again. Take it a little further up beyond the midpoint so that you polish the capsule, do a little bit of dissection, and it'll divide it into 2 and even 4 pieces if you want. And then even through a small pupil, it's actually quite easy to go ahead and pick up those 4 pieces. In patients with corneal opacities, again, sometimes you don't have enough reflex or view to be able to do a good chop. So in those patients also, again, the Miloop actually works very well. Even with a dense cataract, you can easily break these up and then go ahead and safely emulsify them. So some of the advantages to summarize is, again, a very versatile device, not just hard cataracts, but even smaller pupils, patients with IFIS. You can use it without hooks. The shiny reflex at the back is what you want to look for, especially in the initial few cases, to make sure that you're in the right plane. The forces that are applied are very safe and gentle on the zonules. And again, it can be used with a CTR, no problem. And no matter how leathery or dense the cataract is, it will go ahead and divide into 2. And trust me, the first time you use it, it is astonishing how little force it takes. And it can definitely reduce your overall surgical time and also the phaco energy that is used. And also, coming back a little bit to the SICS and phaco debate that was initiated, SICS is an excellent procedure, has its place, but as these phaco machines are getting better and better, and we have incredibly stable fluidics, we are actually relying more and more on the fluidics to extract the lens rather than just the ultrasound energy. And in this particular case, this machine was going up to 700 millimeters of mercury of vacuum. And even at 685 with this hard cataract, it's incredibly stable to just emulsify it quite easily. So as machines are getting better and better, phacoemulsification, even in these very hard cataracts, is a safe option for your patients. Thank you.
Thank you so much, Dr. Sartaj. It's an amazing technology. It's a great value for money, and there is no heavy investment. But I don't know why it is not popular. How many of you are using Miloop from the audience? No.
What is the material used for making the loop? How does it differ from the stainless steel wire which is used for the tonsillar snare technique?
So it is a nitinol filament. So it has much better memory than stainless steels. So as a result, when it opens up, it actually opens up in the exact shape of the nucleus rather than just an oval or a round. The posterior part is curved, mimicking the nucleus. It is a little softer, a little more elastic than stainless steel. So it's less traumatic, more malleable as you are sort of deploying it inside the nucleus. Lesser chances of you causing any kind of damage inadvertently.
How much does it cost and is it reusable?
It is cost-wise, it's roughly about 13 to 15,000 for a device. One device will give you about 4 uses, 4 cuts. So after that, it locks out, then you cannot use it anymore. And I feel initially when this device was launched earlier by Ian Tech, and then even when Zeiss acquired it, it had no limit on how many times you could use it. And I have used some of those devices, so those we would ETO. The thing is, the filament over time does tend to fray and break or even bend out of shape. So I can understand why it has a limited use, but even more than 4, I'm sure you could use it, but unfortunately the device locks out. Some surgeons will prefer to maybe use 2 in one patient and then 2 more cuts in another patient. But from the company itself, it is a single-use device.
Excuse me, initial cases, what are the difficulties you faced?
Making sure you insert it, smoothly, because we tend to put instruments based on the shaft itself, but here you have to first use the loop, guide that in, then go in. The second thing is just making sure that you're in the correct plane. For that, I found rather than trying to open it, completely horizontally, open it at an angle so that it's rubbing against the nucleus. When you start rotating it to get it behind, be very watchful that is there any movement of the nucleus happening. That means you've not opened enough. And that tends to be sort of a psychological thing that in the first few cases we are quite fearful, so we don't open it adequately. But again, because it's elastic, open it as wide. It does not cause any damage to the capsular excess as long as it's well done. It might stretch the capsule, but it will not damage it or tear it in any way. Then after that, the actual division part is quite easy, but it can be a little tricky at times to remove it also, because again, if you don't have the muscle memory of rotating it enough, you might capture the iris or the capsule bag as you're retracting it if you are too fast. So just retract it slowly, making sure the loop doesn't get engaged in anything.
Thank you so much.
Sir, this looks very promising. The problem with this is mostly the people who come with brown cataracts are not into that economic state of going for that high package of surgery. Also, like you talked about, in small pupil, you can use it to do the inadvertently, if we go above the rex's margin, so what all damage can it do and how can it complicate the things?
Fair enough.
Because we can't see the margin properly, right, in small pupil, especially in PXF.
So that's why when you are using in a small pupil, especially if the cataract is not too dense, you want to make sure you're already sort of going below the cortex. Then that will make sure that as it opens up, it's opening up in that plane and it'll actually go underneath the capsular margin. The second point is, let's say, okay, even if you missed it and you're opening it up towards the sulcus, you will feel a reasonable amount of resistance, which tells you that something is not okay, because when it goes in the bag itself, the amount of resistance faced is negligible. So that's quite comfortable. And again, coming back to the initial point that how is this different than stainless steel? Because it's not very rigid. Even if you're in there next to the zonules and you start bending it, it'll not damage the zonules.
So if we have halfway opened it, we can close it again and then.
Absolutely, absolutely.
Okay.
But the thing is, at that point, if let's say you are there
Yeah.
and you're struggling,
Yeah.
don't close it over there.
Yeah.
Then rotate it again, back up a little bit, and then gently close it.
In your experience, has it caused any damage in any case?
In my hands, no.
Okay.
When I have tried training others, only once has it, and that also because again, when they were struggling, they just quickly closed it.
Okay.
But otherwise, no. I'm using in a lot of cases, very safe device.
Thank you, sir.
What are the chances of getting zonular dialysis? Because the zonules are weak with the brown cataract, with the beginners, and as it is not that much controlled.
No, it
because
is.
the nucleus was getting down while you were studying it.
No. So the nucleus is not going to go down when you are snaring it. The nucleus can come up a little bit. But at that time, it is already relatively free and you're getting two pieces that are coming up like that. You're not getting a whole nucleus that is coming up and bringing the bag along with it. So when that nucleus comes out, there is no risk of it damaging the zonules or the bag. The risk is that it comes and hits the endothelium.
It may flip.
That's fine. If it can't flip. It can't flip because it cuts it.
Okay.
It cuts it. So it'll cut. It'll get two pieces up, but flip can't happen.
You see, as he had mentioned in his talk,
Second instrument.
the reason why there will be no stress on the zonule is that the force of the loop is centripetal. There is no force acting on the zonule. All the force is only directed onto the nucleus and cut into two. So there is no movement which is taking place which can have effect on the zonules. That is why you can do it even if the zonules are not strong.
Thank you.
How about applying this thing in SACS, manual SACS?
Yes.
Your view.
You absolutely can. I think someone mentioned the economic parts. It would change the economics of SICS completely, but it'll be an excellent device for those very hard black cataracts.
We can cut down the size of the incision and.
Yes. It's very good for.
Yeah, initially they started with the wire loop.
Yes.
So another question is, you said 4 cases we can do.
Yes.
So in between, like one case you finish in the same day you have to do all the 4 cases, or
So
you can keep it in some formalin chamber or anything?
no,
like
you
that?
can just dry it, ETO it, and use it again.
Okay, ETO.
Yeah.
Thanks.
So I also wanted to just share my experience. I don't have that much experience, but I've used it a few times. And yeah, no complications, like it was pretty easy learning curve. And yeah, this was new, that the video that you showed with the capsular tensioning, I've never tried that. So that was great. And also just that there was no second instrument that you had for some of the cases on top. You could just close it and it didn't really do any damage. That was also new, so thanks for that.
Any other question or comments from the audience or anyone who wants?
Sir, one question. Suppose if there is a posterior polar cataract along with this hard cataract, and you are not able to diagnose it pre-operatively, then there are chances of this PC rent during applying this loop?
There can be, yes.
Yes, one thing.
But so I've actually had a discussion with one surgeon where they were like, if it's a soft posterior polar cataract, maybe you can actually put this in the cortical plane and then use it. And I was like, no, I don't think that can happen. But the reality is, if it's a posterior polar, what other options do you have?
Yeah.
So with dense cataracts, by default, you proceed assuming it is posterior polar. You'll do a gentle hydro if at all. It again, as long as you don't open it too much, it's not traumatic at all. Okay. It might actually, I mean, depending how strong the edges of that posterior polar defect are, it might leave it intact also.
Okay. Usually the posterior polar cataracts are associated with a soft white mature cataract rather than a nuclear and hard cataract. So the chances of having a PPC with a hard cataract are very less.
Any other questions or anyone who thinks of starting it, any point someone want to ask, if any barrier they feel in starting the simple and economical technique? No? So we move on to the next talk then.